impact of exercise. I mean, though the topic says specifically insulin sensitivity, I'm going to talk about sort of diabetes in general with a focus on pre-diabetes. So this is a picture of a hospital. I have seen many familiar faces in the audience. If you are in the area, please do come and visit. I'm going to talk a little bit about extending the primary prevention of diabetes, which is sort of pre-diabetic state. Evaluation of the individual, prescription, mechanism of action for benefits, and special precautions for diabetes and conclusions. Okay? So we'll go through it pretty quickly, and we'll spend a few minutes on each area. Now, for a conference like this, I really don't need to tell you what is pre-diabetes, because by now you had a lot of talks and you know exactly what it is. These slides, some of the slides are used straight from the American Diabetes Association slide deck. So this is stuff that you know, okay? Today, more and more, at least in my practice, and what I'm going to try and do through the talk is to help share some of my experience for whatever that is worth, okay? In real life working with the population. I tend to look at the HbA1c a lot more than what I would look at specifically a fasting or a post-lunch sugar, okay? And we want to get that down over time. This again is straight from the American Diabetes Association sort of slide deck. And the point is, they're giving all the various treatments to be used at different levels of HbA1c. The point is, whatever the HbA1c, physical activity of more than 150 minutes per week is a very important component, as is losing 7% of body weight if the BMI is more than 25. Okay? Now, this is something, honestly, that everyone knows. I mean, not just people in the audience, but all of your patients. I don't think there's any adult alive today, in a sort of urban setting who doesn't know that, yes, they should exercise more, and yes, they should lose weight if they are overweight. The really hard part is actually doing it. And that's the hard part, right? I'm sure all of you all are the experts, you're the professionals, but I'm sure you yourselves are not able, not everyone, but you're not able to do everything you want to do, right? If 100 is your sort of overall target, very few people, I'm sure, I know there are some in the audience, but very few would be at 100, right? You'll be anywhere from, 30 to 80 to 90, right? So the trick also that we need to focus on is how do we get them to do? And because this is a scientific symposium, going in just the slides. So as you can see, they've chosen 3 studies, and the Diabetes Prevention Program, DPP, is a very famous one. It actually showed that if you took a pre-diabetic population, you can actually reduce their risk of developing diabetes within 3 years by 58%, and even 10 years, which is hard to sustain, by 34%. And these results were actually even better than giving them metformin. Okay? And all of these studies look at massive numbers of people. So they're not small studies, they're well designed, they're serious studies, and they all look at the 7 to 10% weight loss. I personally tell people who come to me, we just say you need to lose weight. Or the doctor says you need to lose weight is a meaningless statement. I think you should tell them 2 things. You should tell them the amount you're looking for, and that can be a range, of course, and the time frame. That's important because people have unrealistic expectations. You ask them how much weight you need to lose. I need to lose 15 kilos. And how much time? 2 months. How long it took you to put it on? 20 years. When people always ask, you want to lose 15 kilos? Fine. When will you last 15 kilos lighter? And that's when I was in college, 22 years ago. It took you 22 years to put that on. You can't, at least look at 22 months, right? Because the only way you can lose weight dramatically is to starve. And you can do that, people do that, but you can do it for 1 month, 2 months, maybe even 3 months. Beyond that you can't, right? So just come back on. So, getting people to do long term. So you tell them how much weight and in how much time. So as a rule of thumb, I try and look at 5 to 10% body weight, and we look at 6 to 7 months. As a rule of thumb, I would look at 1 to 3 kilos a month, depending of course where the person is starting. If someone's starting at a very, very, very high weight, then they can lose more than 1 to 2 kilos a month. So again, this is a class A recommendation, okay? Using exercise, maintaining at least 150 minutes per week. And you know that class A means it's the highest level of evidence that there is. So I'm not going to spend too much time now just talking about these papers. I don't think I need to convince anyone in this audience that exercise is good for you. If you need it, then put your hand up and spend more time on these things. But I hope not, alright? So then let's just look at a basic evaluation. And though we're saying, in this case, though the conference is about pre-diabetes, there is always a fine line, right, between pre-diabetes and diabetes. I mean, ultimately, it's a continuum, it's a spectrum which the person is on. And we, of course, look at the history, family history, comorbidities. The word comorbidity became very well known during COVID. Everybody, the lay public also knew of a word called comorbidity because we spoke about blood pressure, diabetes, and weight as the biggest comorbidities which led to higher deaths with COVID. Social history, lifestyle, and behavioral patterns. I do believe that a lot of lifestyle, especially even for weight, it's not here, it's out here. Okay, you have to get into the person's head. Because like I told you, the people that we deal with, they're not stupid. They know that they, whatever, need to eat less and exercise more. But how to do it is your expertise, where you hold their hand and, make them do it. It's a challenge. It's not easy, right? Today, lots of people use technology, they use apps, things like that, which is helpful, okay? In fact, I'll show you an experiment, okay? Remember this number, 3021. Okay? Depression, anxiety, disordered eating. I'm not going to spend too much time on that, but obviously a large part of the audience are nutritionists, dietitians, and you definitely know that disordered eating is going to affect, diabetes or any chronic health condition. Okay? Sorry for the ugly picture. Sorry. But you also need to look at the cardiovascular system, because diabetes and heart disease are just so linked to each other. Today, diabetes is considered a cardiovascular equivalent, which means what? If someone has diabetes, you treat them as if they have heart disease. Okay? Including statin, aspirin, whatever else. Okay? A very large number of people with diabetes are going to develop heart disease, and vice versa, a large number of people who have heart disease have comorbid diabetes as well. And women are at higher risk. The large women audience out here. Women are at higher risk of developing heart disease from diabetes than even men. Okay? And India is, as I'm sure people have spoken to in talks earlier, is the diabetes capital of the world, right? We're just getting more and more numbers. What about stress testing, exercise testing? Do we need to do that? And well, the guidelines are that everyone doesn't need to do it, to put it in simple words. Just because you're diabetic and you're starting an exercise program, you don't have to. And in our environment, we also tend, frankly, to over-test. And one of the reasons we tend to over-test is we are fortunate that in our country, all these tests are very cheap. It's cheaper to do a stress test than to have a full meal in Starbucks. I mean, it's ironic. That's a fact, right? 1,500 rupees you can do a stress test. And you have one of those fancy things I thought about that is like 600 rupees a day. So, it's available. So we tend to also use it more than we need to. Okay, so we need to be a little bit careful about that. But if the person has a lot of comorbidities, their risk profile, please never treat a disease in an isolated manner. You're not looking at the person's sugar only. You're looking at everything associated with it. Right? When we talk about the insulin resistance syndrome, there's going to be belly fat, there's going to be blood pressure. All that is ultimately going to lead to cardiovascular disease, heart disease, and stroke. People rarely die of diabetes. They will die of cardiovascular disease. Okay? Diabetes will lead them to it. Or they will die of kidney disease. Diabetes is leading them to it. They're not dying of high sugar per se. Okay? So when you stress testing, just some of the things, sometimes diabetics, because of the neuropathies, they don't get symptoms as much. And even a lot of times women don't have heart disease symptoms, or they don't have traditional symptoms. They may have things like shortness of breath as opposed to chest pain. They will not get that. And the diagnostic accuracy of a stress test can sometimes be slightly compromised in diabetics. So then often we do a thallium test or a nuclear screening kind of a test or a stress echo or something more than a regular stress test. Okay? Okay. So then let's look at the exercise prescriptions that we're going to look at. This is an old kind of mnemonic which we all know. Look at the FIT principle, how many days a week should be exercise, how intense, how many minutes, and what type of exercise. So as a very general rule of thumb, I would want my diabetics to be active every day, especially if they're type 1. Because type 1 is a game between sugar and insulin and medication, food and exercise. You kind of got to balance all of that. And we know that exercise has a great insulin-like effect. So if a type 1 diabetic is exercising every morning, then we might reduce their insulin dose for the morning. But that same person one day doesn't exercise in the morning and exercise in the evening. So now evening more insulin and exercise, sugar goes down. Morning less insulin, no exercise, sugar goes up. So the same person who was beautifully controlled, suddenly by changing their pattern, got out of control. Of course, I'm exaggerating, each person may not be that much, but when they're type 1, they tend to be a little more brittle where sugar is concerned. So I would like a type 1 to be ideally active every day and be more regimented, same time of day and things like that. But type 2, it doesn't matter all that much. They can be treated as, if I may use the word, so-called normal people. Okay? But type 1, I would want them to be more regular. Heart rate guidelines, the usual somewhere between 55 to 90%. Start low. I believe in all, these are all what I call special populations. Start low and progress slow. But progress, right? It doesn't mean you stay stagnant. If someone's walking half an hour a day, doesn't mean they walk half an hour a day at the same speed for the rest of their life. They can either increase the speed and or the time. Okay? There'll always be a plateau, but let's work at getting the high plateau. Or we can use the rating of exertion scale, how hard the person feels when they exercise. Okay? You don't have to necessarily have a heart rate monitor and be measuring it. It's just by perception of effort. And there we say you should be in that fairly light to somewhat hard zone. Not very hard, not very easy. So it shouldn't feel like you're taking a walk in the park, but it shouldn't at the same time feel like you're sort of so out of breath that you can't carry on a conversation if someone's walking next to you. Okay, so 60 minutes a day or more continuous non-accumulated bouts, at least 150 minutes a week of moderate intensity or 75 minutes of vigorous. And those of you like to get technical, 6 METs, metabolic equivalent, is the difference between vigorous and moderate. So a very brisk walk would be at the borderline of moderate, and anything more than that would be vigorous. Okay. Types of aerobic exercises, we know it: walking, running, cycling, elliptical, rowing, stair climber, any of these. Okay, these are some of our patient valid exercises. In fact, this morning I ran a 16K and my patients ran a 8K because we're all getting ready for the marathon. So everybody can exercise. It's not that if you've got heart disease or cancer or something, you should not exercise. Resistance training is also very important. Over the last 40-50 years, we have a lot of evidence around aerobic training, but the last 20 years, I would say, a lot of evidence around resistance training is also coming up. And quite frankly, almost all, or I would say all the benefits that we saw or we see in aerobic training, we will also get in resistance training. Okay? And especially as people grow older, especially women post-menopause, you start losing muscle mass. So you don't need resistance training to sort of pose in front of a mirror. You need it for activities of daily living, picking up something from the ground, going grocery shopping, going for a weekend trip with a 10-kilo bag, right? All of those things are what you require. So at least 2 days a week, 2 to 3 days a week if you did it, great benefits, and great benefit for your sugar as well. Okay, So again, you don't need to do, even if you did one set, just one set of 8 to 10 exercises, okay, involving your major muscle groups, 4-5 upper body, 4-5 lower body, and each set was 10 to 12 repetitions, you'll get great health benefits. And all of this can be done as little as 10 to 15 minutes. It doesn't take more than a minute for exercise. So if you did 10 exercises, 10 minutes, 1 minute rest, 20 minutes. This is minimum, and you get good benefits. You do more, you get more benefits, right? But the good news is that even one set gives you great health benefits. You don't have to do 3, 5, 7 to get health benefits. You want to do it, you enjoy it by all means, okay? Interval training, high intensity training has become a big buzzword. It's being used more and more. I have mixed feelings about it. Very simply, why? I think it's great for those who can do it. But I would rather get someone to do something first. Start slow, build up your base. The problem is people just get excited, oh, in 3 minutes I'll finish my workout, and they go all out, injure themselves, hurt themselves, get sore, and they stop. So, in especially your patient population, I would rather start with moderate training, build up a good solid base. Then, if they want something out of the ordinary, something new, let's push them a little, let's do something, okay? This is the picture, just to caption it, we say sitting is the new smoking, right? Which means we know that obviously smoking is bad for you. You also know that sitting for long hours is also not that great for you, and obviously you're in confidence if you have to. But the point is that as far as even for sugar control, blood pressure control, just being sedentary. So you even have this term called marathon couch potatoes. You can have people who are marathoners. They wake up in the morning 4 days a week and run between 1 to 2 hours, but the rest of the 23 hours they're just sort of sitting on the couch, right? That's also not good. Obviously it's better to run and sit on the couch than to not run and sit on the couch. But the best option is to be, active and being physically active. And I tell patients that when we're talking about losing calories or from a weight loss perspective, right? And all of you know the biggest number of calories a person loses is just by being alive. Then BMR, right? That will be like what, 70%. Other two areas will be your exercise and physical activity. Please do not mix the two. They are different. Exercise you will do 20, 30, 40, 60 minutes once a day. Maybe 3 days a week, maybe 5, maybe 6, maybe 7 days a week. But there's a limit, there's a ceiling. We don't have much to play with in exercise. But in physical activity, it's almost limitless. The average person will walk 2,500 steps a day. So it's not difficult to walk 10, 12, 13,000 steps, especially if you use public transport in our cities. It's quite easy to get that, okay? I've got 5 minutes, right? Okay. So people are using different techniques, okay? This is a standing desk. You can sit and it can work sometimes. So a lot of you are researchers. You stand up. This is a fancy one that goes up and down. You can do something like this. If you have an office, use something like this when you're doing your reading, little bit of work on the computer, talking on the phone. Use a standing desk, right? I saw this cute cartoon yesterday, so I thought I'll share it. It says, if inactivity is bad for you, how come trees live for hundreds of years? Okay, but we're not trees, so we don't have that. Okay, so mechanism of action, increase insulin sensitivity, improve lipids, lower blood pressure, weight control, blood glucose, so basically all the good stuff. Okay, this audience is not need to go. How does it actually work? So skeletal muscle is your main site of insulin resistance, right? When we're talking about insulin resistance, the skeletal muscle is your main site. And when you're exercises improve the skeletal muscle glucose transport. Okay? Increase the number of insulin receptors. Some receptors called GLUT4 transport proteins. Those. I got my stopwatch on. When did you start? It's 19 minutes. Okay, fine. Let me rush through some of them. Okay, special precautions, look out for hypoglycemia. When someone's diabetic and start exercising, sometimes you go down, keep a sugar stack ready, available for them. Okay? And so we check all our patients before and after. And this is, I won't waste time on this, but what I must have seen 25,000 before and after blood sugar, okay, in patients. And even a simple thing like a 10 to 15 15-minute walk dramatically brings down sugar instantly. Okay? Okay, so let's go to conclusion. Exercise is vital both in the prevention and treatment of diabetes. Skeletal muscle is a major site of insulin resistance. 4 to 6 days a week of aerobic exercise as well as strength training is good. If your blood sugar is low before you start exercise, have a snack. And sometimes you need to change the site of insulin injection when the person is exercising. So they normally, if they put them in the leg and they're exercising, the leg muscle takes it up very quickly. Plus you're exercising, so you might get hypoglycemia. So your site and your dose might need to be changed. Okay? So I'll end with this nice nutrition joke again. So I'm on a low carb